Great. Well, thank you very much, George. Really appreciate the introduction. And it's both great to follow Bose, but also intimidating to follow Bose. I thought that was a fantastic keynote, continuing in the tradition of really powerful keynotes to recognize and remember a very powerful person, Trish Reidenberg. So now I'd like to turn to our panel here, and our panel is Healthcare System Preparedness, ensuring broad access to new innovations. And we're going to really focus on two things over the course of the next 50 or so minutes. The first one is the current state of the healthcare system globally, and asking the question, is it ready to deliver innovations in diagnosis, treatment, and care to patients? We heard yesterday on two panels, if not more, a really strong sense of optimism about the possibility of near-term innovations coming into the clinic and helping patients. We know we'll have a disease-modifying treatment in front of regulators very soon, and when approved, this will place new demands on the healthcare system. We also heard about advances in diagnostics, and integrating these into practice will require adaptation. That's focus one. Focus two, as George laid out, this is the third prong of the attack from the Davos Alzheimer's Collaborative. So we'll talk about healthcare system preparedness and what the DAC or Davos Alzheimer's Collaborative is doing to help these systems transform and be ready and deliver innovations to patients. So to discuss those two pieces today, we have a great panel, and this is a group who's been around the world together in so many different ways. So first, we'll have Phyllis Ferrell. She's the global head of external engagement in Alzheimer's and neurodegeneration at Eli Lilly and Company. We'll have Anika, who is the executive director of Mass General Brigham, and she's also with the Department of Global Health and Social Medicine at Harvard Medical School. Both Phyllis and Anika are the leads for this Davos Alzheimer's Collaborative Healthcare System work. We also have Elina Suzuki, who is, I think, the leading thinker on Alzheimer's at OECD. They didn't give her that official title. Her official title is Advisor to Director of Employment, Labor, and Social Affairs at OECD. We also have Dr. Soeren Mattke, who we've known for a long time, started with his role at RAND, where he pioneered a lot of the work you're going to hear about today, but now is with the University of Southern California. Both Elina and Soeren are on our work group and have contributed to what you're going to hear today extensively. And then we also have Denis Horgan. He's the Executive Director of the European Alliance for Personalized Medicine. As we heard in the cohorts discussion today, that there's a real focus on driving precision medicine into Alzheimer's and focusing on engaging developing countries. And Denis is an expert on both those, precision medicine and developing countries. So we have a great panel, and we hope this is pretty dynamic. So I'm going to just start by asking Phyllis a question. So Phyllis, if you could just lay the foundation for us by describing the situation we face when we talk about healthcare system preparedness, and why is this an issue?
Thanks, Drew, and to the organizers for having us. I wore my fuzzy vest in inspiration from the Lausanne mountains behind me. I wish we were all together again. But I think this topic has actually come up several times already in the last couple of days, most recently in the clinical trial cohort conversation. And if I step back to the time period when we were running the solanezumab studies, and I came from a commercial background, I'm not a scientist, and we were celebrating that it only took us 18 months to find 1,000 patients for a clinical trial in the United States. And I remember scratching my head and saying, how can we possibly be celebrating that it took us this long when there's 5 million people with this disease in this country? And there weren't a lot of competing studies at the time, and the inclusion criteria was not incredibly challenging. This was pre-biomarker inclusion. And I started scratching the surface of that and realized that really what we were seeing in clinical trial recruiting was the front line of this challenge that we have in our healthcare system. which is that patients are not flowing through our healthcare system in an efficient or effective way. People are not thinking about their brains as the vital organ that it is. We're not taking care and having those conversations with our doctors. And as a result, we're catching Alzheimer's disease at a very, very late stage. So it's only, relatively recent with the advent of imaging biomarkers that we found out that, the plaque in the brain, this Alzheimer's pathology starts 10 to 20 years before symptoms. And so what that means is this mindset that we have in the healthcare system of Alzheimer's disease, this mental model of someone who's very old, very functionally compromised, is really a mental model that's working against us, because what we've learned is we need to treat this disease earlier. It's a progressive, relentless neurodegenerative disease. And the sooner we engage, the more likely we're going to be able to slow down the progression. And unfortunately, our healthcare system today just is not set up to do that.
That's great. Thank you very much, Phyllis. As we've thought about the work of this group, and a key element to this is of the Davos Collaborative overall, but also the healthcare system piece is creating a learning laboratory for governments. And I know you've looked into the commitments governments have made. And I just wanted to ask you before we move on, are governments thinking this way? Is there an open door to push on, or what needs to happen to get governments engaged?
Yeah, it's a great question, Drew, and a really, really important one, since the majority of healthcare systems, even in the US, when you're thinking about somebody 65 and over, is a single payer government system. What's fantastic is over the last 10 years, we've seen a major shift that's everything from this being the decade of healthy aging to, and I think we may actually have some of the visuals, the G7 Dementia Summit in 2013, which was actually the genesis of these Lausanne dialogues and the legacy events that came after that. The G20 communique, we've had World Health Ministers meetings, and there's a lot of common ideas on paper about where we need to go. Thinking earlier, brain health mindset, making sure that we're also improving quality of care at the end of the disease. So throughout the entire disease spectrum. But right now, a lot of that still remains on paper. And one of the goals of this work stream, in fact, the specific goal of this work stream, is how do we get this out of that hugely important government support in terms of what's in writing, but actually plug it into a healthcare system where it'll be right in front of a real patient.
Yeah, that's excellent. I'd like to go to Anika next here. Anika, you're the co-chair of this effort, right? You hear what Phyllis has laid out, and you know the work ahead of us. So what is this group going to do? What is the Healthcare System Readiness Group going to do to affect change?
Yeah, big question, Drew, and one that a lot of big brains are needed to answer. So Phyllis has done a great job of outlining sort of our call to action and why this is so critical. And then the follow on to that is obviously, how do we operationalize systematic healthcare readiness and really go from macro to micro? Phyllis often sort of uses a tag of healthcare happens locally. And so as much as we need systematic change, how do we get that down to the patient? And so, part of my participation as a co-chair in this group is that, Drew, as you mentioned, I'm an executive director at Mass General Brigham, where I lead our enterprise data and digital health program. It's a $500 million effort to really create new technologies and innovations rapidly that can impact our patients across many clinical areas. We have 67 different projects underway. And so what I like to contribute to this group is a lot of those lessons learned around ideation and how you operationalize that. And so I'd say, the first challenge that we face with the DAC group and what we need to answer is, why are we doing this and why? And what's our end state? So we really have to anchor in an outcome. The path to that outcome may be variable, but we really need to put a stake in the ground of what we're going after. And so with the DAC work group, we built out this framework. It was briefly up there a minute or two ago on our health system capabilities within dementia. And these different nodes, we want to select one and really put some rich criteria around it and really layer on outcome metrics that are specific, measurable, and accurate, that we can know what we're going after and how we're going to measure success. Our second challenge is that we need to develop a suite of capabilities that can be leveraged in diverse settings. We're not just solving for, health system preparedness in the UK or the US. We want to look at this globally. And so how do you prioritize what's best when the context is variable? And that's really where you've got to develop a capability around rapid iteration and deployment. And that's where this learning laboratory comes into play. How can we take one of those framework nodes and the outcome metrics and now look at a diverse set of solutions to explore and see how they can contribute to the impact against the target? And we don't want to just test one, we want to test many. And again, move very quickly to get to that outcome and have those shared learnings that we can share across multiple different interventions. And while it's really good in theory to be able to work against a framework and work against a culture, and I really want to encourage this group, and maybe part of our discussion on this panel can be also creating the right environment and culture that is going to allow for innovation to take flight. It is not necessarily within the DNA of governments or, legacy healthcare systems to move very quickly. A lot of my research at Harvard looks at collaboration models, specifically in dementia clinical trials. But when I marry that up with what I do at Mass General Brigham, I really see this incredible opportunity to weave together collaboration frameworks for dementia, but also in the innovation space. And what does that take? What are the personalities and temperaments that we need? And I think it really begins with a lot of accountability, and that comes through trust and really investing in the right people in the team that can drive this forward. I really hope that we're able to create radical transparency in the work that we do within innovation, because we want to elevate those lessons learned, share it widely, what's working and also what's not, and then really make sure that we're sharing that across a global network so we can really create change when it comes to health system readiness.
Thanks, Anika. And I just want to remind everybody that if you have questions for this panel, put them into the chat function on Attendify, and we'll be sure to get to those. So if you could start entering those, that would be great to get a queue. Anika, you mentioned nodes, and that's a bit of a term of art for our working group. And so I just want to see if we could pull up the slide with the nodes and go back to Phyllis. And Phyllis, could you just talk us through nodes and patient pathways? I think it's still a bit of the foundational, it's a lot of the foundation of this effort. So we could ask the team to pull up that's it right there. Perfect. Phyllis.
Well, I'd be happy to. We have a fantastic working group. Anika and I are very lucky that we've got experts from around the world that really have a passion for healthcare system preparedness. But one of the first things we realized when we kind of got into our first meetings was we were all solving the same problem, but defining it a little bit differently. And as a result, we often found that we were talking across each other. We found that our solutions could not be shared very easily. We were using different nomenclature, different words. And to be honest, a problem like healthcare system preparedness is really, really big. So if you kind of tried to eat a problem in one bite, it choked. So one of the things that we did was we decided we really needed to break this problem down into what we called nodes, but really that's just digestible bites. So how could you look at how a patient flowed through the healthcare system and be able to measure, was it happening efficiently and effectively? And that's where our patient pathway came from. So you'll see in the slide, the dark navy blue line at the top are the themes that were coming out of all of those government communiques that I mentioned earlier, because we wanted to make sure that we were really staying true to this goal of bringing those government commitments down into the healthcare system. But then when we looked at how patients actually flowed through the system, we ended up with these essentially 10 steps. And so on the left-hand side, you see 4 gray nodes that really look at activities that happen often long before a patient ever talks to their doctor. These are, do I have a public that's aware of brain health and dementia? There's lots of great initiatives there, but do you have a good public awareness? Do you have consumers, patients, caregivers aware of brain health and activated to do something about their brain health very early on, especially now that we know that lifestyle modification can make an impact much earlier in life than most people are thinking about the risk of Alzheimer's. And then, of course, the physician being able and willing to have that conversation, and then the payer or the healthcare system making the connection. Is that person actually talking to their doctor, or are they talking to their clergy? Because that's a change that's going to happen. Then a patient enters into the healthcare system, and you've heard already about early detection. Detection here is, it's one thing when we're talking about asymptomatic disease. That's where you do have a lot of questions about the ethics of, identifying amyloid pathology in an asymptomatic patient. But here we're just actually talking about somebody who has symptoms and not having them wait for 4 years from the start of those symptoms for someone to take them seriously and for themselves to take it seriously. So can you really get early detection of those earliest subtle cognitive symptoms and have someone take that seriously and move someone further into the funnel for greater diagnostic testing, where then now you see those, advanced biomarkers that can confirm pathology. After that, you end up in the kind of care model. And the first step is a personalized care plan. That is where we should be aimed. Alzheimer's disease affects a lot of people, but it affects people differently and families differently, and needs are very different. So do we have personalized care plans in place? Do people have access to not just the drugs, but also to the services and the support that they need? In some cases, in some countries, that services and support are delivered through the healthcare system. In some cases, those are delivered through communities. So now that's why, Anika and I talk about local healthcare. Are we connecting people to the services they need? And then, of course, the dementia care. Are people having a therapeutic environment where they're mobile, they're still staying connected to families, and they have the social interaction that they need? So this is essentially our patient pathway. And as Anika mentioned, we really tapped into her learning laboratory experiences in innovation at Brigham Mass Gen. And we're really looking for how do we execute at each of these nodes in a way that different countries can compare what they're doing, share ideas, and be able to pilot, experiment locally, but then share broadly because we're all using that same framework and language.
That's great. Thank you, Phyllis. So appreciate the foundation that you two have laid for this discussion. Elina, I'd like to turn to you. Given your position at OECD, you have a great understanding of the healthcare system challenges that we're facing now and that will likely emerge in the future. Can you give us your sense of what the landscape looks like and what we need to do to advance the healthcare system?
Sure. So this was a really great overview of the deck. And I think, a little bit of what I want to touch on really points to the need to better prepare the health system. So at the OECD, for the last couple of years, we've been doing some work exactly on this. We wanted to look at, what are OECD countries, which tend to be among the most advanced in terms of aging populations, furthest along that demographic transition. What policies do they have in place to care for people with dementia? And really, what does this look like from prevention and particularly from detection, identification, all the way to the end of life? And what we found, I think, really points to the fact that we are in almost every country, I think you could even say in every country, behind where we need to be already. We're already playing catch up, which isn't a a good start. So, when we're talking about the nodes, like Phyllis just very helpfully looked at, this point of detection, for example, we found that less than 40% of the countries that we spoke with said that they even had a sense of the proportion of people who were diagnosed at all. I'm not talking about any kind of advanced diagnosis even. It's just somebody who at some point, either from a specialist, but also from their GP, had some kind of Alzheimer's disease written down, even just based on a simple test. And yet, even just that basic metric, less than 40% of OECD countries could report. So we're starting really at a deficit, because if people don't even get into the system, then how are they going to access the services that are available to them? And there we found there are quite a lot of community-based services available. I think this is an area where you see a lot of really interesting work coming both from the health system itself, but also from advocacy groups, non-governmental organizations like Phyllis was talking about. But if people aren't being told that they have dementia in the first place, then it's really, really difficult for them to be channeled to the right services. And even where people do receive a diagnosis, we found that in many cases, healthcare providers and physicians were ill-equipped to actually point them to these services. So far too few people are getting personalized care plans, any kind of care plans, oftentimes any kind of information. That kind of nightmare story of someone being told they have dementia and sent out the door really remains the norm in too many cases. And so, those are a couple areas where we found just kind of how also I would say the lack of data and the lack of, what we can even measure really underpins how difficult it is to change the quality of care that people are receiving, because it's incredibly difficult to target people that we don't know exist, even if we have a sense that they do. And then moving on, we found very similar things, both in terms of a fragmentation of a care once they have this diagnosis. A growing proportion of diagnoses are made, for example, in primary care. And yet primary care is one of the most poorly linked at centers of the health system with other areas. So even if someone has been told by their physician that they have dementia, is that diagnosis going to show up when they go to the hospital with a broken hip? Or are they going to be, just seen as a really troublesome patient, for example? And then we also see that long-term care systems, that kind of the endpoint when somebody eventually needs care, are too often ill-equipped to deal with people, both in terms of training capacity and also the suitability of many care facilities. And you asked kind of about looking forward, and I know everyone's COVIDed out, but I do think, the pandemic is a really stark reminder of a lot of the pre-existing weaknesses that we have when it comes to caring for older people, including and especially those with Alzheimer's and other dementias. And I think it really underscores a lot of the weaknesses that we need to better address going forward, because we know that we already have so many structural problems in terms of underinvestment, in terms of staffing, in terms of patient safety. And these challenges are only going to grow. So recently we did some work on the long-term care workforce more broadly, not only on people with dementia, but by 2040, the OECD countries are going to need an additional 13.5 million workers just to keep up the current ratio of care workers to older populations based on aging populations. Because so many more people are aging into 65 and over, and particularly, the oldest old 80 and above. And as that really grows, the challenge in terms of keeping up with providing even just the services we have now, but we want to move beyond what we have now, which we know is inadequate to provide even better care. And yet, for example, fewer than 1 in 4 care workers today have a tertiary education, even as we know that people who need care have increasingly complex conditions, are living increasingly longer. People really need to have specialized care, and we're not paying people enough. There's too high retention. There's too low retention, and we don't have adequate recruitment. So I think there are a lot of areas where we're seeing that already we don't necessarily have adequate systems in place. And yet we know that the demographic trends really suggest that these are going to be increasing problems going forward. So, if anything comes out of the COVID-19 pandemic, I hope it's a stark illustration of the fact that these problems already exist. And when pressed, it's incredibly difficult for them to manage as it is. And I hope that we're going to be able to put a lot more focus into strengthening them now so that we have the capacity to care better going forward.
Elina, so much great stuff in there. 100% agreement from the group without even asking that we're all COVIDed out. But your point about the care delivery and need for care workers. I mean, there has to be disruption in the care delivery system because just throwing more bodies at the problem isn't going to work. And I think that's one of the things we hope to see out of this work group. Your point around data, I thought was excellent. I was encouraged yesterday when I heard that China and Canada in their national plans had put a priority around surveillance and data collection. And I think that's really critical. And this is a point, too, where I think WHO's Global Dementia Observatory plays a really important part. And we heard from WHO yesterday. So hopefully some of the foundation that just speeds our project is being put in place. And then the last piece I just want to pick up on is your point about the rate of underdiagnosis. The work group has identified, when you look at those nodes, that our starting point is going to be detection and diagnosis. And it's really to your point, to your points you made and the data that you raised. Soeren, Mattke, I'd like to go to you here. I know your work over the last 5 or so years has really looked at the bottlenecks that will develop with the introduction of a disease-modifying treatment. Could you give us a couple minutes on the bottlenecks, the impact of these bottlenecks? And we've mentioned the role of primary care in this panel already, and just how you see primary care fitting into it based on the analysis you've done. So I'll turn it over to you, Soeren.
Yeah, thank you, Drew. Pleasure to be here, although I'd rather be in Lausanne like so many of you. Yes, we have looked over the last year at the better half of the G20 countries, how ready they are for a disease-modifying treatment. And if Elina points out that dementia care is in poor shape, think about pre-dementia care, because that's something we don't really do at. So country after country, we looked and we find a similar picture in sort of different shades of gray. We don't have enough dementia specialists to diagnose people. We are lacking the PET scanners to make confirmatory diagnoses. We even don't have enough infusion chairs for the vast majority of treatments that are going to be intravenous delivery. But we also, and that's harder, we also have a capability gap. If you think of memory care today, it looks a little bit like psychotherapy, right? Small practices, very diagnosis-focused. Specialists describe and quantify the state of cognitive decline, and then link people up with social services and other resources, because that's what they can do. In the future, if you go to a disease-modifying treatment, memory care has to look like oncology, right? Like large practices, multi-specialty, complex task shifting, biomarkers, imaging, infusion delivery, very complex differential diagnoses, and personalized treatment. Clinical trial sites manage that today, but it's really only those sites that are ready for the disease-modifying treatment. I'm an eternal optimist, so I think this can be fixed with money, smarts, and dedication. So I think it's not an impossible task. And we have done this in other specialties, right? We've seen specialties like immunology or dermatology transform from sleepy, disregarded, and ridiculed specialties to high-end tech practices with very attractive opportunities and very attractive options. We can do this. And like both had pointed out, technology is improving vastly, which allows us to bridge many of these gaps with scalable ideas. Some of you may have seen our paper recently that an automated blood-based biomarker test can all but eliminate the wait times for specialist visits and PET scanning in the US, just as one simple test that can be done in any setting and is easy to interpret. But that, going back to your first question, Drew, brings me back to the mother of all obstacles, which is primary care. Right? I used to think we don't have to worry about primary care because even if only a fraction of treatment-eligible patients get referred to specialists, we saturate the pipeline so quickly that we don't really want to tantalize patients with the prospect of a treatment just to put them into a queue. Right? If we manage to clear the queue, we really must get people diagnosed at an early stage, not like 4 years after they have their first symptoms. And so we need to focus, and that's kind of where I go next, is we need to focus how to incentivize primary care, how to treat them, how to give them workflow compatible tools that they can actually manage early stage diagnosis and rapid referral to a definite diagnosis. So thank you. Drew, are you on mute?
You're on mute, please.
You missed my brilliance. I'm seeing the number of questions come in, and I think they're great, and I'm definitely going to get to these questions, but just want to let people know that following this panel, there will also be a discussion around the Davos Alzheimer's Collaborative generally. So if we don't get to your question now, don't worry, we will get to it. So Denis is joining us here, and Denis was introduced to us by our good friend Lydia Landman at Roche. And just want to bring you into the conversation here, Denis. In your introduction, I highlighted your expertise in precision medicine. The key to precision medicine is biomarkers. We've been hearing a lot about biomarkers over the last 2 days. Soeren also highlights the fact that these biomarkers are key to alleviating some of the infrastructure bottlenecks. So you sit in Brussels, you look at political institutions in Europe, and I know you have some thoughts on how you can get biomarkers more widely embedded in clinical practice. And I think we could learn from that. So I'm hoping you'll share that in your response.
Thank you. Pleasure to be here, and great to hear all the panelists before this. I mean, the story of personalized medicine is the story not of treatment per se, it's the story of how to identify patients earlier, to treat them earlier, and to provide a better quality of life. And primarily, I mean, personalized medicine or precision medicine oncology. And precision medicine has been focused on oncology, not in the area of Alzheimer's. So there's a recent area that we have been started looking into. And this also relates to why healthcare systems have not been ready, because a lot of biomarker tests, a lot of treatments have not been available for regulators and policymakers to look at. And this is an issue then why healthcare systems have not been prepared. But even if we look at the oncology sphere, there is a lot of treatments being developed, but it's very hard to find different patients. And that's often because tests are not available to identify patients earlier, to treat them earlier. So the question is, how can regulatory frameworks and policy frameworks be developed to do this? And a big issue has been identified by different speakers already is what is the minimum testing that should be available in different countries, and what is the optimal standard of testing that should be available? Some simple biomarker testing to optimal testing, if you look at cancer, from BRCA testing to comprehensive genomic profiling. And what is the resources that need to be put in place to facilitate this? So if it's infrastructure, what do we need to put in place to have better labs? Or what tests need to be put in place? How is data collected between different healthcare systems? As was mentioned by colleagues, there needs to be more surveillance. But often it's different methodologies of how data is collected, then how data is stored, and how data is visualized. And this is important in terms of how do we make decisions in terms of investment? How do clinicians say this should be a treatment given to a certain patient, or a payer decides whether this brings value? But a problem often with biomarker tests, these are not reimbursed. And this is the key issue, because often it's only the therapeutic, because the regulators or the payers will say, okay, this will extend the quality of life of a patient or a citizen. And the question is then, how do we change the paradigm in healthcare systems, saying that by identifying a patient area, this will give a longer quality of life to a certain group of patients. And this is a big issue that we struggle at the European level. How to convey the importance of testing is a key issue from a payer perspective. But often this needs the whole healthcare systems to be changed. Because in Europe as well, I mean, you can have a large global framework, as we talk about, that we can say these are guidelines that people will abide by. But the question then is how this is implemented in local healthcare systems, because local healthcare systems have different ways of interacting, and they have different priorities and there's different interests. So you have patients, you have clinicians, you have different specialists, you have the regulators, you have the payers, and then you have hospitals, and different actors have different ways of dealing with different issues. So one needs for the different types of stakeholders to speak with one voice and what changes policy or government should do, because the role of governance is to regulate how different types of actors will interact with each other. And there you have different types of regulatory frameworks. You have clinical trials regulation, you have the data issue, which leads to reimbursement, you have the research funding. And the key issue is how these different paradigms link together. And this issue means you need a more of a holistic framework to convey to policymakers what changes should be brought into healthcare systems. And since now we have more opportunities taking kind of how science has evolved more recently in Alzheimer's and related dementia, how can these be advances be brought into healthcare systems? So the key issue there is looking at, testing. What is the need from the primary physician to refer patients earlier, and what are the tools they need, and what do specialists need to get reimbursed? So it's more about incentivizing the relevant stakeholders to cooperate together. And this needs, a reimbursement framework to support this. But then you need the infrastructure there as well to sustain it. The data infrastructure, the research infrastructure, and the broader healthcare system infrastructure. And that will lead to bringing this type of biomarkers into healthcare systems.
I like the fact that you brought up oncology, and I think there's an opportunity working with you in other disease areas because it's not just Alzheimer's that needs what we're laying out here. It's all of medicine and all of care and treatment. So we look forward to that partnership with you. I kind of, in my question, steered you towards your expertise in Brussels, but just to take a little bit wider lens here, knowing that you've worked extensively in the developing countries, any differences to note? Or is it the same situation, same problem?
All healthcare systems, every healthcare system has the same problems. Some healthcare systems have more. In the European region, for example, only 3% of the healthcare budgets are spent on prevention. And it's a resource issue. And the resources are still, there's a shortage of resources everywhere in the low-income countries and high-income countries. The question is the case of how do we rationally allocate resources in society to better target different disease pathways, to treatment pathways. And this is a key issue. The shortage of healthcare professionals is one issue that was highlighted by colleagues. But the question is, what are the mechanisms that we can have multidisciplinary boards that can be set up to share expertise between different regions? And the question there is, how do we share data between different healthcare systems? So this is the key issue. And then, of course, in low-income countries, then you're looking at minimum standard of care. How do we identify patients earlier? But this goes back again to simple testing issue, not to the therapeutic side, more to testing. How do we mitigate the problems there? Because maybe they will not, in a low-income country, they will not have the sophisticated healthcare systems to give the optimal quality of life standard that should be given. So the question there in focusing in low-income countries, will be really identifying patients at an earlier stage and focusing on preventative to early diagnosis. This will be a key issue, because there at least we can understand the burden of the disease. I think policymakers know they need to do something, but the question is, what should be done, and what does the global community or the different communities agree what should be done? This is a key issue. I mean, one area that we're working on a lot, if I go back to cancer again, is on the area of lung cancer. And the question there is, should we do lung cancer screening? Should we do screening programs to identify? And then the community is very fractured in terms of whether we should do screening programs or not. So the same issue there is, what approach should a community say to policymakers to speak with one voice? These are three key things that we should do. And this then, looking at low income or high income, then you can see which we should prioritize. So you can say, these are the three key challenges that we should focus on in specific regions. Low income countries, to your question, should focus on, I would say, on prevention in terms of early diagnosis to mitigate the harm of late diagnosis and the onset of late dementia and Alzheimer's disease.
Yeah, that's a great comment. It reminds me of some of the comments we heard yesterday from Ishtar. And the idea that an innovation in a lower resource country is most likely to be the most scalable idea is something that's really stuck with me. I want to go to the questions in the chat, and if I could bucket a couple of them, and I'm going to just open this up, so if whoever wants to take it first, just kind of jump in. But the question is kind of boil up to the stigma around Alzheimer's disease essentially has a chilling effect on anything we're hoping to accomplish. It doesn't ever start that patient pathway. We don't get to eat the nodes in bite-sized pieces, as we've heard from Anika and Phyllis. So what's the panel's reaction to the impact of stigma on our work?
So Drew, I think the stigma on anything related to brain and mental health is real. We see it, not just in Alzheimer's disease. You see it in depression and schizophrenia, and there's just this feeling that you should be able to control your mind, and if you can't, then you must be weak. And I think that stigma is different in different countries. I think generationally it is changing a bit. But it's one of the reasons why you'll see a lot of focus in brain health. Because I think if you're talking about, do I keep my brain healthy, that is a very different conversation than, do I want to get diagnosed for Alzheimer's disease? Many of you know my father passed away of Alzheimer's disease. I didn't make it fast enough for him. And it was one of the things that was very upsetting for him. It was if that word was used. And yet I saw so many times that my family could have gotten ahead of a crisis if we'd been having that conversation with his providers. And, here I am in a situation where I know the field and I have access to resources. I just can't believe that if we can't shift this dialogue to taking care of your brain and potentially talking about lifestyle modifications, anything that makes that conversation safe with the doctor will get us ahead of the costs that we're facing today. A diabetic is not a good diabetic if they're having cognitive challenges that are undiagnosed. So we've got to shift, I think, the narrative to taking care of our brains. And then I think there's a lot of hope that will have spillover into continuing to have that dialogue once maybe something's not going the way it should. I'd be interested if the group thinks it's possible. Yeah.
Yeah, I totally agree. I think we need to shift the narrative that at the moment is so focused on dementia to something more uplifting and sort of actionable, which is, I like to talk about memory care, not dementia care, because that means there's something we can do. So as we go from care to cure, I think people will open up more about these diseases as they have opened up for other mental health problems when they became manageable. I think also we need to talk to the professionals. And I remember one attending of mine in medical school, he was always adamant about you do not have the right to decide for your patient what they should know about their disease. You need to give them the chance to ask and give them access to as much information as possible and help them. You can't just say, I better not tell him or her that they have an untreatable end-stage disease.
You know, Drew, to build on what Soeren just said, which I think is really important as well, is can we shift that decision to the patient? The number of people that have come to me and said, you know, my mom was diagnosed and they're telling me that she's too late for a clinical trial. And, you know, that's heart-wrenching for someone who wanted that as a choice. I mean, in oncology, we brought that up. You get a choice to participate in a clinical trial as part of your personalized care plan. And we have a healthcare system that's taking that choice away from people. I think Soren's right. Any way that we can shift that back. And then, oh, by the way, if that helps us speed therapies to the market, that's a win-win. But that choice should be in the patient's hand, and not in a system that's just chosen to not address the issue.
I mean, I agree with what the two panelists said. I mean, I think a key thing is socialization of the disease. There's better awareness that there is. One can be better earlier diagnosed, that you can improve your quality of life if you get diagnosed. If we take cancer is seen as a death sentence, if I go back to this, 20 or 30 years ago. Now, because of different treatments that are becoming available, one can have a good life. If you have breast cancer, if you have colorectal cancer, any of these major cancers, one can have a good quality of life. So, I mean, I think it's socialization so that one becomes accepted. It's not a bad thing to have a disease. One can get treatment, and it's a duty of policymakers and governments to respond to these needs. There needs to be more investment in research, and this research that drives innovation needs to be brought into healthcare systems faster. And this is the key problem that we have in healthcare systems. We have a nice, good innovation that's developed, and it takes far too long, except for the COVID vaccination, not to mention COVID, that can, or if I work for UK regulators, that can fast track everything before the world and implement it. But the question is, how can this be done more effectively? So I think socialization, saying, okay, of course, Alzheimer's disease was a huge challenge. It is a huge challenge, but we want to tackle it as a global community. And saying there's nothing wrong to have Alzheimer's, and you having it can support other patients in future. I mean, tackling this disease by participating in clinical trials and research. So I think socialization also is important and say how you can participate to tackling this disease as a society. I think this is important to say, not to say that it's a stigma and you stay in your room and nobody should see you. I mean, I think you should also participate and say, okay, I want to fight and also support other patients, future patients that may get this disease.
Before I ask my last question, Elina, do you have any thoughts to this question?
Yeah, I mean, I think what Phyllis was saying about kind of broadening it out and talking about brain health or memory care, or as Soeren was talking about, instead of talking about dementia care, I think is really important, and it's encouraging to see these kind of trends towards that. Similarly, I think talking about healthy aging more broadly, where we're really tying Alzheimer's and dementias as well to other preventive behaviors in the way that we talk about them in the context of other chronic conditions. I do think that there are encouraging steps that we've seen in terms of reducing stigma, but I think at the same time it's still far from where we actually want to be. And I think it's going to be as well, honestly, something that will probably change a lot more quickly when some kind of treatment comes on the market. I think part of it right now really is this perception that there's nothing that you can do. I think that also, this is also something that we found that healthcare providers, when they don't have adequate training, when they don't have adequate time, when they don't see a lot of older persons, for example, this is often a kind of conclusion that might keep them from giving a good diagnosis, from having somebody go see a specialist, from even diagnosing at all. And so I think there's so much that can be done already, obviously, to improve quality of care, to improve quality of life with a dementia diagnosis. But at the same time, I think, to see this kind of paradigm shift in thinking is going to take a lot more activism. I think we've seen so much going on there already, which is really encouraging. But at the same time, I think this is something where we'll really see a change when people no longer perceive it as something that is without hope. And I think, going back, for example, to this perception of cancer as a death sentence versus knowing that there are so many options today, really came as well with the advancement of treatments as well. So I'm hopeful. I think we're going in the right path, and I think that this is something that will probably also hopefully speed up in the near future.
So clearly there's no shortage of work here to be done. We have 2 minutes left. And so I want to do 2 things with 2 minutes. First, I want to start with Anika and then go to Phyllis and just tell us what we can accomplish with the Davos Alzheimer's Collaborative Healthcare System Preparedness work. And then I'd like to go to Elina, Soeren, and Denis, and just what do we do? What's your one takeaway for this group? This is an agenda-setting meeting for CEOI. Tell us what needs to be done, and we'll see what we can do. So Anika, Phyllis, Elina, Soeren, and Denis, in that order. Anika.
All right. Well, what's so wonderful about a program like the Davos Alzheimer's Collaborative is that it's greenfield. And, we have really been given, the opportunity to put pen to paper and think about this in a new and novel way to go after health system preparedness. One of the things that I love about just innovation and, design forward thinking is that we don't necessarily know the exact outcome. We don't necessarily know what tools and solutions we will call on yet. And the exciting bit is that the technology and the, products that are in the market, they're moving so quickly. COVID has, for better or for worse, really catalyzed the adoption of virtual care and digital technologies at scale nationally, here in the US, but then globally as well. How are we going to be able to leverage that now as we think about health system preparedness and the things that we want to go after in early diagnosis and detection? So there's a lot of operations that we can put in place to then sort of mine these new capabilities and technologies and bring them on board. So the work that, Phyllis and I and the broader team are going after is making sure that we put that stake in the ground of what outcomes we want to deliver in terms of the impact to patients, to caregivers, for the health system at large. But then the journey of how we exactly get there, well, that's going to be the fun part. That's great.
Phyllis.
Now you see why Anika is a great co-chair, because she calls that fun and I think it's terrifying. I think for me, mine would be a call to action of let's not wait. I think there's a lot of people that say, oh, this healthcare system thing, it'll straighten out as soon as we have a therapy. And well, yeah, about 10, 15 years after that therapy is launched. And I am lost patience with us. We can do a better job today caring for people. I think it's just completely unacceptable that people aren't getting the best care they possibly could have today because we're not, doing things that are already, for example, in the legislation in the US on an annual Medicare wellness visit. So I think what DAC, the Davos Alzheimer's Collaborative, brings is a sense of urgency. Let's collaborate and let's move faster. Let's not wait. We've already waited too long to make sure patients are getting the best care they possibly can.
And to my co-chairs on this effort, thank you so much. Elina, your turn.
It's hard to follow both Anika and Phyllis, and I think I'm going to kind of steal from both of you as well. But I think, absolutely this point that we're already, not to put it negatively, but we really need to be focused on this yesterday already, and I think one of the things that I would hope Doc can also bring in terms of a call to action is maybe moving beyond the usual suspects, broadening this agenda to new people. Obviously, the World Economic Forum has a broader profile It's incredible, and I think one of, this goes back as well to the previous point about stigma. I think one of the issues is just socializing it so people are used to it, so people hear about it, so people think about it regularly, instead of only in crisis mode. And I would really hope that this is one of the things that we can also kind of take out of this, is to broaden the audience who's paying attention as well, so that I think that it generates as well new ideas, and also puts more pressure on health systems to take up a call to action. So I'll leave it at that.
Thank you, Elina. Soeren.
I agree with Phyllis and Elina. So, but seriously, we cannot wait for this transformation from care to cure to occur organically. Like Phyllis said, this will take 10 years, as we've seen in other specialties. And so we need to make that a little faster than that. And for that, I think we need to get it in front of other audiences, like Elina said, because we in our little bubble know the problem and we know the numbers. And some of you may even have read my papers. I bet you that most health ministry officials don't have a clue. They think, okay, we'll have a treatment, fine. So next problem. And we need to get to them the message that having the treatment doesn't mean the treatment being available and accessible. And we need to get to them the message that this requires action. Action that might not cost a fortune, but needs to be tackled, and it needs to be tackled soon.
Soeren, I read your papers. They're right here. Denis, it's over to you to take us home.
My God, thank you. Well, as Elina said, it's very hard to follow all these great recommendations that came out there. I guess a call to action would be, declaring early diagnosis and appropriate treatment of Alzheimer's-related dementia as a public health priority. I was seeing this as a clear call to action. Looking at, not use about COVID again, but getting the public health community to say early diagnosis will support better treatment of patients. So getting a public health component to this and saying that there should be a public health priority of early diagnosing, and then which leads to, obviously, the necessary treatment, would drive forward the innovation into healthcare systems. So I would say this would be a suggested clear call to action that could support and then bring the healthcare community, rather than sailing in many different ships, bringing them in one ship to sail together. And this would be very helpful to harness the excellent speakers that have been speaking at Lausanne these few days. You're mute again now.
Thank you, Denis, and thank you to this panel. Fantastic discussion. With that, I'm going to turn it back to our fearless leader, George Bradenberg.